I'll confirm you.
Okay. Almost 200 doctors আমি পঠাইছো মানে লিংকটো মানে নর্থ ইষ্টৰ গোটেই doctors. So এনে 45 40 50 doctors.
ইমান ক্ৰাউডেড হৈ গলে কোভিড টাইমছ অলপ কেয়াৰফুল হ'ব লাগে বাবা।
আজি ৰিপন ছাৰৰ এটা হেৰি দেখিলো খুব ধুনীয়া মানৱ বোমা
কেতিয়াবা মনলৈ আহে লিখি দিও আৰু
কি হয় কোনো ঠিক নাই ঠিকই ক'লে আপুনি কোনে ফটাব কোনো ঠিক নাই
কোনে ফুটে আপুনি we don't have the remote controlling capacity we do not have the controlling capacity
দিলীপ ছাৰক বৰ গহীন লাগিছে
হা
দিলীপ ছাৰক বৰ
নাই
গহীন
আপোনালোকৰ কথা শুনি আছো
ঠিক আছে শৰ্মা ছাৰ সব ঠিক আছে
গুড ইভিনিং
ঠিক আছে না আচ্ছা আচ্ছা
one more Anil is not coming
হয় স্যার তেওঁ ফোনটো কাটি আছে বাৰে বাৰে ফোন কৰি আছো মই তো সাকে কিবা ইমার্জেন্সি হ'ব পাৰে
তেখেতে এনেকৈ অকমান কথা কৈছে নহয় জানো দুপৰীয়া
মোৰ কথা হৈছে গধূলিও কথা হৈছে মানে আবেলি কথা হৈছে
We are live on audience link.
Okay, we'll start. Good evening, sir. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I, Nazrul Haq, welcome our eminent doctors who have joined us for today's panel discussion, titled Views on Vildagliptin. To help us navigate through the meeting, we have with us today Dr. Ripun Barbajari, sir, who will be our moderator for today's panel discussion. We take this opportunity to welcome moderator of the day, Dr. Ripun Barbajari, sir, is one of the leading senior physician and diabetology from Shivsagar and huge diabetic experience. Also, I would like to introduce to you our galaxy of panelists, Dr. Dilip Barua, sir, senior consultant physician and diabetology from Shivsagar, Dr. P.K. Sharma, sir, one of the senior consultant physician from Nagaon, Dr. Anil Kolita, sir, consultant physician from Dibrugarh, and Dr. Anupam Datta, sir, consultant physician and assistant professor of Assam Medical College. We would now invite Dr. Ripun Barbajari, sir, to set the context and start panel discussion. Over to you, sir.
Thank you. Thank you, Mr. Najul, for this kind words of introduction. And thank you, Alchem Laboratories, headed by none other than Mr. China, for giving me the opportunity to moderate this today's CME with this galaxy of very highly talented and academician panelists along with us from Dibrugarh, Nagaon, Dr. Sharma, he's been senior to us. Well, with this few words, respected ladies and gentlemen, panelists, we shall be talking about a drug which has become very recently off patent. And you know, the beauty of this molecule is that once it has become off patent, it allows a lot of companies coming with a huge amount of vildagliptin from each and every company. In fact, all these biosimilars, there's flood of the biosimilar vildagliptin in the market. But the beauty is that when it was on patent, the per tablet cost was something around 45 to 50 rupees. And once it is off patent, the cost has come drastically down to 10 to 12 rupees per tablet. And it is estimated that the per year cost of the on-patent position, it was something around 1,700, 1.77 thousand. And once the patency is lifted, the price has drastically come down to, the yearly cost has come down to somewhere around 4,500 per year only. But ladies and gentlemen, the drug is, of course, you might have imagined, it is vildagliptin I'm talking about. And today's seminar will be talking on vildagliptin and only vildagliptin and its different aspects. The drug, as you know, it has been discovered long back. It's supposed to be the oldest gliptin in the market, somewhere way back in 1998. Well, that is not the reason why we need to discuss vildagliptin today. Number one, my point is, number one, the Wikipedia trial, the largest trial in the history in type 2 diabetes medicine, it tells us that when you use a single drug, the more than 50% of the people become out of target within 36 months, that is in 3 years. And if you continue with the same drug, at least 75 to 80% of the people become out of target, glycemic target, I'm being so in terms of A1C, fasting, post-prandial blood sugar, become out of target at around the 9 years of duration. So durability is a major concern in the treatment of type 2 diabetes nowadays. And number two, the greatest impact of this particular drug I'm talking about, in the last ASD consensus in 2018, it said that combination therapy has got very little evidence to start with in type 2 diabetes. But after a trial, a very robust trial, known as verified trial, and that was presented in last ESD Barcelona conference in 2019. And after you see the result of this particular trial, there has been a paradigm shift of the guidelines, both from AD and ESD. And it now says that yes, combination therapy has got a lot of evidence, at least now after the trial is over. So to tell us something about the trial, the verified trial, and what is the impact on clinical pathological impact, we do have the very senior panelists along with us, Dr. Promise Sharma. Dada, I just want to ask you how you see the impact of this particular trial verify in our regular clinical day-to-day practice. Over to you, Dada.
Thank you. Thank you, Dr. Prabhu. My best wishes to all the panelists and stay positive. I wish all
Voice is not coming clearly.
Our voice is a little unclear.
And network of internet clear.
In between, sir, I would like to inform you that I think Dr. Anil Kulita is there with us. Dr. Anil Kulita, good evening and welcome to you.
Good evening, sir. Good evening.
Welcome, Dr. Anil.
So,
Hello.
the discussion today is on a drug that is oral hypoglycemic agent that is under the group of DPP-4 inhibitor. This group of drug is very safe because we have tried for a lot of years. There is no incidence of any hypoglycemia, and in relating to weight gain, this is weight gain weight neutral. So this combination of reliability and metformin is a very good combination. Because we always, in case of type 2 diabetes mellitus, we always initiate with a metformin, that is a classical drug. But in case of US prospective UKPGS study, it suggested that when you start with a monotherapy in the long term in the US, say about 50% of patients by 2 years, they will require another drug. And in 75% in 10 years, they will require another drug. So in case if you add this DPP-4 inhibitor, that is your vildagliptin with metformin, they delay the progression of the disease process, and thereby need of more drugs will be used. Because you see, this is a very unique combination. Both metformin and vildagliptin both are weight neutral, and their risk of hypoglycemia is nil, because they are only dependent on glucose and insulin level. So if you combine these drugs, there is chances of hypoglycemia is less. So if you continue these many drugs, you can delay the needs of third drug in case of, or in there is this chance of initial stage therapy. So you require can prolong the drug therapy for a long period. This is a very important point. And there is one study that is your verified study. This verified study is the first study to show the long-term benefits and glycemic durability of an early combination treatment strategy with vildagliptin and metformin compared to the current standard of care, late combination therapy in patients with newly diagnosed type 2 mellitus. So it is from the study also it is says that if we combine this metformin and vildagliptin, both are of different action, but both are of different dose, but the action is almost identical. And if you continue it, and then these two drugs may be continued for a long period, and we can delay the initiation of insulin for a long period. So this is a very remarkable study. So hence, this is we can try. The previous idea was that metformin is to initiate with the metformin, and then we wait. But it is in that from the I have already mentioned that in the UK study, that monotherapy need after a few years there is another second drug. So if you from the initiation if you start with two drugs, that is optimization, and the result is very good. It is found that most of the patients can continue this treatment for a prolonged period in comparison to a single drug. So I hope this combination of vildagliptin and monotherapy has a bright future in the long run.
Thank you, Dara.
Okay, so I expect more from my next panelist regarding different its uses in CKD, in cardiovascular disease, and everything will be discussed in the later panelist.
Thank you, Dara. Very finely you have elaborated the effect of metformin and vildagliptin combination, and that is very well proved with this trial. And you might have seen that with the combination therapy of vildagliptin and metformin, the primary failure has been extended to 5 years rather.
5 years.
With monotherapy, it is almost 36.1 months, that is in 3 years. And with this combination, it has gone up to the 5 years. So that is the beauty of this particular drug. And if you look at the secondary trial, secondary failure, there has been a tremendous 26% reduction in particular with this combination if we add on to metformin or insulin also later on. So this is the beauty of this particular aspect. With that, one question to you again, Professor.
Yes.
Would you have expected the same result if we continue with the sulfonylurea and metformin?
No, actually what happened, if you sulfonylurea metformin, there are chances of hypoglycemia is there. Most of the patients, they do not follow the proper diet after the tablets, and they develop very often hypoglycemic episodes. And there is also chances of weight gain. Though metformin is weight neutral, but sulfonylurea induced weight gaining. So in that case, this combination, vildagliptin and metformin, they are both helpful in reducing weight, in controlling weight, and the risk of hypoglycemia.
Again, disconnected, I think. Again, sometimes it is disconnected. Well, let me approach Dr. Anupam Datta, the young physician and a very good speaker. And
so from that point, I think I cannot say that it needs further evaluation, but I can say that the contribution will have a bright future.
Yeah, absolutely, you are right. And if you look at the ADOPT trial also, the durability is very much less in the sulfonylurea compared to metformin and compared to rosiglitazone in that particular trial. And in this trial also, verified trial also, if you look at the durability trial, durability compared to the monotherapy, it has got tremendous durability over more than 5 years. Anyhow, and there are a lot of reasons why the gliptins work better in Asian Indians. There are so many, but prior to that, let me go to Dr. Anupam Datta, a young assistant professor, young academician, a very good speaker, and academician par excellence, I must say. And about you, Dr. Anupam Datta, my question: how do you see the builder as a worthwhile add-on to other antidiabetic medication, be it sulfonylurea, be it metformin, be it pioglitazone, be it insulin, and be it SGLT2 inhibitors. Over to you. Can you follow my question, Doctor? Hello. Hello.
Sir, unmute karo.
Yeah, can you hear me, sir?
Yes.
Yeah.
Thank you very much for giving me this opportunity, sir. And just before answering your question, which is really very interesting question and important question, that how do you look at the combination and especially of vildagliptin and DPP-4 inhibitor? I would like to go back a little to a theoretical part of it. When we were students, we were taught that pathophysiology of diabetes had three triangles. One was reduced insulin production from pancreas, then reduced glucose utilization from the liver, and increased glucose insensitivity or insulin resistance from the muscles. This was the triad which we were taught in our MBBS days. But now the concept has completely changed after last 20 years. And now the concept is of the omnious octet, which includes the gut, the kidney, the fat tissue, adipose tissue, the pancreas, the liver, and also the one of the very important thing which we do neglect, or probably not much research is there, is the brain gut reflex. And probably we have targeted all these. So now SGLT2 has come for kidneys, DPP-4 inhibitors and anti-incretin analogs have come for the gut. We have metformin, which works in all the ways. Sulfonylurea was working in the pancreas. And now the concept is almost like that we have in tuberculosis. So in tuberculosis, what we do is we start with a combination therapy of the rifampicin and isoniazid. So when this diabetes, first of all, the diabetes treatment was thought that first we give metformin and wait for some time. Then we add sulfonylurea. Then we wait for some time. Then we add something. We wait for some time. If that is not working, we give insulin. So this has been regarded now as a treatment to fail. We are waiting we give one treatment, we wait it to fail, then we give another treatment, we wait for fail, then we give another treatment. This concept has gone, sir. And nowadays, like in hypertension, like in other chronic illnesses, we straight away the concept should be a holistic approach. And whenever we talk about holistic approach, it should be a multi-drug approach. And I'm really sure that in very future, we will not even come about combination of two. We will come with the concept of the polypill, where we'll be targeting the kidneys, we'll be targeting the gut, we will be targeting the pancreas, and a holistic. And probably one day a new drug will be discovered which is work on the brain and the gut brain. Yeah, why some people are more hungry, why some people do not take much food, why some people eat much but they do not have diabetes, whereas some people eat less but they are obese. So that is a new concept which is coming, and probably that is the reason where that is the direction in which we are moving, that combination drug is going to come in the future. Secondly, sir, coming to your question proper, what we think about vildagliptin. So vildagliptin is relatively a very safe, a very, I will say a very gentle anti-diabetic drug. It doesn't cause hypoglycemia. It causes a modest reduction in the HbA1c. It doesn't have much side effect. We do not have GI problems like in metformin. We do not have allergies and much problem. It's a gentle. But when we combine it with the metformin, let's say, which the verified trial has shown very nicely, then the action is well-rounded. And the effect is actually not additional, the effect is actually multiplied. That we do not get the hypoglycemia, because both metformin and vildagliptin do not add up to severe hypoglycemia. The sugar reduces or works, the medicine works only when there is food in the GI tract. The side effects are less. It is a pleiotropic effect, and then there is a cardiac benefit, which vildagliptin has shown, and metformin obviously has so many pleiotropic activity. So this combination is luckily very, what I can say, pertinent, and that's the reason why it is becoming so widespread use, especially with its lack of side effects. If we use sulfonylurea with metformin, which we have used abundantly, the result in HbA1c reduction is very good, but the hypoglycemia and the other complications are also seen. This, on the other hand, silently works, and if we see for a long period of time, the benefit will be much more there. And as there is no side effect, or probably very less side effect, the patients will be definitely using it for a long period of time. So this combination is very good. So, talking about the pharmacokinetics, talking about the mechanism of action, and obviously the whole pathophysiology of a holistic approach, sir.
Yeah, rightly you have said. And you talk about the little bit of pathophysiology in a type 2 diabetes, and you referred the aminos octane. And if you look at the pathophysiology again and again, one of the component is that the lost insulin effect, right?
Yes, sir.
So lost insulin effect, especially more profoundly found in Asian or South Asian or Asian Indians ethnicity. Because one of the factors may be the high amount of carbohydrate. We usually take 65 to 70% of the total energy in terms of carbohydrate. And secondly, one thing is very peculiar, that in Asian Indians, the expression of DPP-4 enzyme inside the gut goes very high.
Yes.
So that could be the reason why gliptins do much better in Indians or South Asians compared to the Caucasians.
Yes.
So my second part of the question to you was, how do you see the combining vildagliptin with other anti-diabetic medication? And second part, so next part, supposing the patient who you want to give vildagliptin metformin combination, suppose the patient coming out to be a metformin intolerant. So what is the next choice if you want to combine vildagliptin with any other drug?
Okay. Sir, it's a very good question. Yeah, there are many people who do not, cannot tolerate metformin. Some people have GI problems. Some people have severe bowel problems also. And there are some reported cases where they have allergy to metformin. So SGLT2 has been used. Sulfonylureas have been used. In combination, I think SGLT2 and DPP4 has come up with single molecules. And while prescribing, there are numerous prescriptions where sulfonylurea has been used along with vildagliptin or DPP4 inhibitor. And obviously, the combination works because both of them work in two different angles. And as the sulfonylurea will be working on insulin secretion from the pancreas. This, on the other hand, works in a completely other way in the GI tract, and the reduction of the chances of hypoglycemia is less. One thing which I have personally seen, sir, is people who work in offices. They take their lunch period is not very definite.
Static.
So office-going people, in them, when they take a heavy breakfast or heavy dinner, at that time sulfonylurea can be used. Whereas in the lunch time, when they take a little tiffin or they do not take much, but we need to control the sugar, we do not want to go for a very high sulfonylurea. In those conditions, I think vildagliptin does a wonderful job in those group of people. And in SGLT2 with vildagliptin, there has been some recent studies, recent trials, and they are showing excellent results because of the cardiac benefit. The price is a little bit on the higher side, and I think if when that goes off patent, that will be a very good combination. But those who can afford a combination of SGLT2 with DPP4, I think the effect will be very good. Their combination has shown very good results in quite a few recent trials. Coming with, sir, voglibos, acarbose, they can be used especially in Indian scenario. With insulin, obviously, it works very nice. And in combination with
glycogens.
These are the drugs, sir.
Thank you so much. You have nicely described each and every combination which can be potentially be given to a vildagliptin. One of the beauty of this molecule is that it increases the insulin secretion through GLP-1, of course, food dependent manner. Whenever the patient takes, then and then the prandial insulin goes up. So that is why with insulin combination, it might reduce the dosing of insulin, exogenous insulin. So with this, thank you, Dr. Anupam. Doctor, please stay with us. We will have the question and answer session later on. And with this, ladies and gentlemen, often we come across so many patients of renal impairment. And treating a patient with renal impairment, that too with diabetes, is very difficult for us. Looking at the scenario that the drug should be absolutely safe from the hypoglycemia point of view. And secondly, it has got a good amount of glycemic efficacy in terms of A1C reduction, in terms of prandial or fasting blood sugar reduction. So may I talk to Dr. Anil Kolita? You are here, I think?
Yes.
Yeah,
Okay.
Dr. Kolita, please unmute yourself. Hello? Najul?
Hi, unmute. আগত unmute আছিলে, এতিয়া mute কৰি দিলে, sir.
Okay.
Yeah, now it's
Okay.
okay. Now it's okay.
Achha. Dr. Kolita.
Good evening, Nipunda.
Good evening. Can you listen to me? Oh, yeah. Then my question to you, how do you see that use of vildagliptin, with or without metformin, in a patient with different stages of renal impairment with diabetes, type 2 diabetes?
Thank you, Nipunda, for your nice question. So all of you know that type 2 diabetic patient with reduced renal function, adequate glycemic control is very much essential to delay the progress of kidney dysfunction. But they are at greater risk of hypoglycemia, even especially with longer acting OSA like sulfonylurea.
Okay.
So vildagliptin provides very much effective glycemic control in patients with type 2 DM and CKD without the risk of hypoglycemia. But all of we know that vildagliptin and other DPP-4 inhibitors and their metabolites largely excreted to the kidney. So dose reduction is required when vildagliptin or other DPP-4 inhibitors are used in CKD patients, except linagliptin. Linagliptin, there is no dose reduction is required. So in stage 1 and stage 2 CKD, no dose adjustment is required in vildagliptin. But in patients with type 2 DM with CKD, especially stage 3 and stage 4, or moderate to severe renal impairment patient, vildagliptin dose should be reduced. Especially, it should be reduced to half, that is 50 milligram daily. The available data or available results support favorable efficacy, safety, and tolerability profile in vildagliptin with type 2 diabetes patient with moderate to severe renal failure. But in case of end-stage renal disease or when eGFR is less than 15, there are several trials going on the efficacy of vildagliptin in end-stage renal disease. But there are several reports of occurrence of acute pancreatitis when you use vildagliptin in end-stage renal failure. But their efficacy is similar to insulin. So more safety data is required to use vildagliptin in end-stage kidney disease. But we can use safely with dose reduction in stage 2, stage 3, and stage 4 kidney disease. So we can even use in hemodialysis patient also. One patient in hemodialysis, we can use vildagliptin, but that share some reports of acute pancreatitis. That's why we should be cautious. More safety data is required when use vildagliptin in end-stage kidney disease patient. Vildagliptin with metformin combination, we can use safely in CKD when eGFR is more than 45 ml per minute. So it provides very some other additional benefits beyond the improvement of glycemic control. It is seen that when we use vildagliptin in CKD patients, there is some other additional benefits also there. So with these few words, I can say that vildagliptin can be safely used in type 2 diabetic patients with varying degree of renal impairment, but in moderate to severe kidney failure, it needs some dose adjustment. Thank you.
Thank you, Dr. Anil. I just want to ask you one personal question. Supposing you are looking at the patient and it's coming with the CKD stage 3 says the SGV, and the EGFR is found to be somewhere around 40 to 45, in between 40 to 45. So out of all gliptins, if we need to select one gliptin, what should be your first choice?
So our first choice is actually vildagliptin we can use with some dose reduction. We can use also linagliptin also. It is very much safe in CKD patient. But in point of view, other side effect point, vildagliptin is very much safe.
Okay, fine. Thank you. Another thing is that
why we need not reduce the dose of linagliptin in case of CKD patients.
that's not much important, of course, because reducing the dose of a particular drug and reducing the dose to half doesn't make any difference. Actually, the dose reduction in case of CKD is not due to the fact that it might increase the side effect, not due to the fact that, but you have seen that even a 50 milligram or 25 milligram of sitagliptin, 50 milligram of vildagliptin will have the same effect in a case of renal, in a case of CKD at any stage. Anyhow, so Anil, you might have come across to the very good trial known as Switchers et al. Somewhere back in 2015. There's a very important study on, I forgot the number of patients, it's a huge study, of course, but the peculiarity is that the study was entirely done on the people over 75 years of age. And it was shown that the vildagliptin lowered A1C five-fold better than compared to the placebo. And the hypo rate was drastically come down to by 50%. So that is the beauty of this particular molecule in the CKD also. With this, of course, we need to talk another one aspect, a very important aspect, the use of anti-diabetic medication in elderly person. So for here, we do have one of the very senior physician and diabetologist in Shivsagar itself, none other than, it needs rather no introduction, is Dr. Dilip Kumar Barua. So I would like to ask you, Dilip Kumar Barua, that how do you see the role of vildagliptin in those group of patients, elderly patients or senior citizens of ours?
My dear moderator, my dear co-panelists, participants and organizers, thank you very much for giving me the opportunity to speak on the panel discussion of vildagliptin. My dear friends, gliptins has revolutionized the treatment of type 2 diabetes mellitus. It addressing hyperglycemia through its effects on alpha and beta cell of the pancreas. All of you know that DPP4 enzyme present in the gut immediately destroy the GLP-1, and DPP4 inhibitors will prevent the destruction and increase this GLP-1 level 2 to 3-fold. This GLP-1 acting on both alpha and beta cells, increasing insulin secretion, decreasing glucagon secretion, and it delays the gastric emptying and increase satiety and decreasing weight. And it modifies disease progression and halting the decline of beta cell function, causing better long-term control. Now, reducing cardiovascular morbidity and mortality, lowering HbA1c2 targets as close to as normal without hypoglycemia. No weight gain, no unexpected side effects in the long term. Now, beauty of the DPP4 inhibitor is that in addition to other advantages, it lowers the glycemic variability. So it lowers the MACE, mean amplitude of glycemic excursion, and it is safe in special populations. The vildagliptin is 85% oral bioavailability, low risk of drug interactions, and 85% eliminated through urine, and 2 to 3 hours of elimination half-life. Now, type 2 diabetes mellitus is among the most common chronic conditions in older adults. Normally, 20% of individuals aged 65 and more are affected, although in nearly 20%, half of them, diabetes is undiagnosed. Management of type 2 diabetes mellitus in elderly individuals can be particularly challenging for a number of reasons, because the elderlies are the special patient population. They have faced a huge burden of complications like cardiovascular complications like myocardial infarction, cerebrovascular complications like cerebral strokes, cerebral death, and other different comorbidities, and end-stage renal disease also. Now, these elderly people as physically disabled, becomes frail, and they are less stringent control, which may lead to acute complications. Now, they have also cognitive issues, may lead to non-adherence to treatment. They have poor appetite and taking less food. All these will lead to hypoglycemia. So, hypoglycemia is the main disadvantage in treating the type 2 diabetes mellitus patients in elderly. Hypoglycemia is more common in older than in younger people. Management in elderly needs individualization of the HbA1c goal and use of drugs that does not cause increase the risk of hypoglycemia. HbA1c reductions were similar in elderly and younger populations who were on vildagliptin. There is lesser drug-related adverse effects with vildagliptin versus comparator group, and there is greater reduction of fasting blood sugar with vildagliptin. My dear friends, thus vildagliptin monotherapy was effective and well tolerated in drug-naive patients in elderly. Vildagliptin treatment did not increase adverse events among older patients, and with mild renal impairment, we can use without reducing the doses. But when the eGFR is below 50, we have to reduce the dose to 50 milligram per day. And hypoglycemia was rare in the elderly patients, and no severe events occurring in use of vildagliptin. Elderly patients who were on insulin therapy or on metformin and insulin therapy, the use of vildagliptin will reduce the dose of insulin, number of insulin injections, and reduce the incidence of hypoglycemia due to insulin injection. So this in elderly people with end-stage renal disease also, we can use vildagliptin at a reduced doses, and this vildagliptin will reduce the cardiovascular events in end-stage renal disease in elderly. So vildagliptin in elderly is effective and well tolerated. Lesser drug adverse effects do not cause hypoglycemia. Vilda does not cause fracture or osteoporosis in elderly. So it's a beautiful drug for elderly patients to use at a specific doses. Thank you very much. Redipun, you're not audible.
Yeah.
Yeah. Thank you, Dr. Dilip, for your nice explanation why vildagliptin is so important while treating elderly people. One of the most important aspect of this treating the elderly people is that there is always some amount of cognitive impairment. They used to double the dose without knowing that, and they do not have much support. So drugs should be very simplified, number one. And second thing is that drugs should not cause at least hypoglycemia, one of the most dreadful barriers of treatment in type 2 diabetes. Now, with this, we are coming to the last part of the discussion. All the time we are talking about vildagliptin. And why should we be so much concerned about the vildagliptin? Why not about the other gliptins? So how do you feel that why vilda is supposed to be superior to other or inferior to other gliptins? What is your opinion in this regards? Because with the off-patency, a lot of companies are charging with a lot of molecules in vildagliptin preparation in the market. But the people who are dealing with the other gliptins, say mostly sitagliptin, the #1 brand in the United States, of course, backed by a huge trial, TICOS trial, comprising more than 17,000 people as a CVOT trial. And all the trials, even the linagliptin has got a very high amount of CVOT trial, comprising more than 1,500 people, the Carmelina trial. And all the trials, although they showed the non-inferiority to the placebo, and these companies are all the time claiming that why are you preferring vildagliptin? It doesn't have a CVOT trial at its own. And the #2 factor is that vildagliptin is not yet been approved by ADA. It has only been approved by the CCI in India, also approved by European Association. So why the vildagliptin is supposed to be one of the best gliptin out of all gliptins in the market? So I would like to know from the respected panelists, what is your view on the vilda in terms of cardiovascular benefit? Yeah, Anupam, you can start it.
First of all the DPP inhibitors, none of them has cardiac benefit. Only SGLT2 has got cardiac benefit, and metformin has shown little bit. Pioglitazone had shown earlier in one trial, in other trials it could not show. Metformin has shown little, but it's insignificant. So none of the DPP4 is cardiac beneficial. Only thing is they are non-inferior. That is because the FDA had made it mandatory to, So if sitagliptin says that we have done cardiovascular safety trial and others have said that vildagliptin has not done, it doesn't make a ground because they have not done, their trials have not shown much of a difference. So in that regard, I will put all of them in an at par. The molecules, all of the DPP4 will be at par. Coming to the renal safety, in the renal safety, obviously linagliptin has an edge. Linagliptin, there is no dose reduction, only 5 milligram works. That is a very good point. But practically, we all see that people who are on dialysis or who are on end-stage renal disease, they do not have as much very high blood sugar. Many of the time, you need not give any medicine also because their sugar is very much controlled. Absolutely. They have loss of appetite. They have so that is linagliptin is theoretically very good, 95% excretion from the gut. But if you see practically how many renal disease patients are there where you will be giving linagliptin is relatively very negligible. Coming to vildagliptin in renal disease, if the patient is already on vildagliptin, there is not much of a dose change. And if at all a little bit of a dose change, which sir said that taking a full tablet and a half tablet doesn't make it change. So if people is on vildagliptin, we can very well continue them if their creatinine keeps on rising, at least till they are dialysis dependent, or if the creatinine does not go very high. That it does not occur in case of sitagliptin. In sitagliptin, that definitely we will need to change the thing. Again, metformin also, after one level, we cannot give. So in that regard, practically vildagliptin seems to be, I would say, at par with sitagliptin. I don't find anything something very superior in them. Oh, teneligliptin. Teneligliptin was an Indian, was very much, I would say,
cheap, easily available. Cheap.
It was a superstar for a very short period of time.
Before of patency.
Before of patency.
Vildagliptin, teneligliptin is highly used.
Yeah.
But after the patency, the prescription of the teneligliptin is diminished, vildagliptin is increasing.
So it was a superhero for a very few
superhero.
For a few years only.
Yes.
After that, now is not.
New will come.
But when we talk about teneligliptin versus vildagliptin, one thing is there, the QT prolongation in the teneligliptin is a little bit higher when compared with vildagliptin. That has been shown in the trial. Though there is no cardiac COVT trial with vilda is a little bit, but the QT prolongation part is not there.
But so Anupam, in our practice, we have seen that with so much of teneligliptin prescription, we have not seen such type of side effects.
We have.
Yes.
No, one thing is now with the QT prolongation, you need to be very cautious and you need to it should come to your brain that which patient you want to do the QT,
Yes,
do an ECG. That is
Yes.
one of the factor. The many times you do not do an ECG so often. So maybe the QT prolongation part doesn't come to our mind also. But anyhow, with that, if we consider, my point of view is that if we consider gliptin, a particular gliptin, we take gliptin, number one, we need to have something very, very seriously about whether we should have some strong RCT supporting a particular gliptin. Number two, we need to, the pharmacological person or therapeutic part, we need to see how much of DPP-4 inhibition occurs at the end of the 24 hours. And what is the way of blocking the DPP-4 enzyme? That is also important. You see, compared to all the gliptins, the only sexagliptin, it is something, I mean, we don't talk about the sexagliptin right now. This is not the point of discussion, is vildagliptin. So vildagliptin is the only molecule that can sustain the DPP-4 inhibition right up to 97% at the end of the 24 hours. But if you compare the same with sitagliptin, the sitagliptin is placed somewhere between 80 or just above 80, linagliptin somewhere in 87%, 84%. But the teneligliptin is somewhere about 60 to 70% only, so is sitagliptin also. So that is number one, because it has the longest duration of DPP-4 inhibition, which is very much required for the efficacy. Number two, there is the studies available with us that with vildagliptin and metformin combination, it can improve the beta cell function by 5-fold compared to the placebo. The study is available. And vildagliptin, although we do not have so much of trial, CVOT trial, it doesn't have CVOT trial, but it will have the lot of real world scenario taking vildagliptin as a molecule. Say one is very recently proposed, not recently, of course, Sang et al., the more than 2.3 lakhs. And it has shown that 50% lower risk of heart failure with vildagliptin compared to sitagliptin. So with sitagliptin comparison, the amount of heart failure, we'll consider the period of, if you continue the period of total trial, that has been found when the amount of heart failure was compared to sitagliptin or sexagliptin with the base, acarbose base, of course, taking acarbose as the base, the sitagliptin, the hazard ratio is somewhere 1.1 and the sexagliptin somewhere 1.2. But here in vildagliptin, the hazard ratio is 7.1. That means there could be a possibility of 29% reduction of heart failure while using vildagliptin. Another trial, this is also a trial which showed that even the first episode of hospitalization for heart failure was pretty less with vildagliptin. You cannot compare head to head with any gliptins. You cannot compare sitagliptin with vildagliptin head to head. You need to have a real world analysis evidence, or you need to have the nuclear meta-analysis. So there's some nuclear meta-analysis that shows that even a hypoglycemia level is compared to other gliptin is much low. And the weight gain also, the vildagliptin is supposed to be the least causing weight gain compared to all the gliptins. And, there are some plus points in vildagliptin, of course, and there's only one trial, CVOT trial. It's just comparable CVOT trial known as VIVID trial. It was also found that the vildagliptin was absolutely safe in terms of cardiovascular thing. But the thing is that in that particular VIVID trial, a very small trial on 254 patients only, there was increase of the left ventricular mass. And that has been repeatedly being exposed by the other companies supporting other gliptins. So anyhow, so vildagliptin for us, the beauty is that the price has slashed down. It can be given to more and more amount of people who are really in need of this gliptin, any gliptins. And so far, so much so that we do have the very beautiful data on vildagliptin, especially Anupam, you might have read the ACE trial when the vildagliptin is compared to the non-gliptin molecules. Okay. This is a huge trial. More than 37 countries were involved, and the very recent, total number of patients is more than 45,000 something, I forgot. But the recent trial in the Middle East, the AGE Middle East trial, It was the number of patients were somewhere to the 4,800 odd. But it was found that the people using vildagliptin, the primary endpoint was the target A1C of 7%. With vildagliptin, along with metformin, the amount of the patient who is coming to the primary, who can achieve the primary endpoint was 76%. But with the non-gliptin preparation, it was found to be 61%. Very, very highly statistically significant. So there's some good aspect of vildagliptin. So there must be some good aspect of vildagliptin, linagliptin also. And regarding the heart failure, sexagliptin, the story is entirely different, of course. I don't want to talk it again and again. But with this, I do not know. I thank all the panelists, and Dada specifically for Mazda at this age. You are coming up to take up the
very nice discussions on vildagliptin is going on. Thanks a lot. I think
if you have a query, and I would like to request Mr. Najrul, if you find some queries from the audience, you please highlight us.
So I'd like to say one more thing. As you know, my observation while monitoring, while working in the field, it has been seen that all of you, I will not say almost, because all of you are a very good prescriber of vildagliptin, and of course, Alkem's brand, that is one more brand, as you know, Blue Vilda, all of you are supporting. And as you know that now in market, one more, molecule, that is vildagliptin sustained release, has come out. Anything, because and it has also been seen that all of you are prescribing this molecule also. If you tell us something about this brand, sir, this molecule.
Sina, I want to ask you,
Yes,
is
sir.
there any lots of studies regarding OD dose of vildagliptin, 100 milligram daily?
Yeah, it is there, sir. It is there.
Shweta madam, can you answer this, madam?
Shweta. I think sir, it is there. Sufficient
Yes.
evidences are there that will provide you. Okay, time to time.
To be frank, Dr. Dilip, we don't need a study in this regards, because all we need is the PK/PD profile. If it can maintain the PK/PD profile with 100 milligram OD preparation with 50 milligram BD preparation, it is same. It is same.
If we prefer vildagliptin 100 milligram daily, then how can we manage the combination therapy with metformin?
You cannot the single dose preparation. You cannot give, of course. You need to give metformin separately.
Then we have to give metformin separately.
Yeah, of course.
But it is better to give with combination therapy.
And with this combination of OD preparation, of course, it was found the PK/PD profile is almost the same with the BD preparation. So that makes the difference. That makes the same thing for us.
But the patent drugs has not coming with single pill.
I think, sir, I should not mention the name. Galvas has not come. But I think, sir, Jalra has already come out. Okay.
Jalra, I don't know.
Few more, 2 or 3 brands is there. But I think we are almost amongst, you can say, first or second. Okay. The brand we have come out with this brand. And I think Rajesh is there. Rajesh Datto, you are there.
I think.
First of all, before we end up, any question from the audience?
Sir, the question unable to seen here. Actually, this is the only panel discussion. The question is not coming in this platform.
Okay.
Ripun,
Yes.
I want to ask a question at last. How can we manage COVID patients with diabetes at the present situation?
Nice topic.
How can we manage isolated patients without symptoms, mild symptoms, moderate symptoms, and admitted patients with moderate and severe symptoms?
No, whatever medicine you gave, you need to maintain the time in a range in between the 70 to 180. That's all. Be it with any sulfonylurea, be it with any drugs, and give the good amount of nutrition, but you have to maintain the glycemic variability within the range of time in the range of 80 to say 70 to 180. It should not go beyond 70. It should not go above.
But
Because
we
you know,
cannot
the
use,
more, huh?
but we cannot use SGLT2 inhibitors
Theoretically you cannot.
because
But if you,
because
no,
because
practically it is
can
not
precipitate
advisable.
acute complications like ketoacidosis. I think.
No, practically it is not advisable. But the thing is that in a very severe, the patient needs to be admitted. Whenever the patient needs admission, definitely the drug of choice is insulin and no other drug is required.
No,
Right,
I am talking about the home isolation patients with mild and moderate symptoms. I think
whatever drug.
I think metformin and gliptins are the best.
Yeah.
Am I wrong?
supposed to be bad.
Metformin and the gliptins are the best.
But
And
if you ask me frankly, if
the patient is continuing insulin, but in the hospital, when the patient is severe, patient is unable to take, insulin is the only treatment. No oral treatment is necessary, I think.
No, as on today, the advice by the guidelines are that whatever treatment the patient has been receiving, if there's a homestay or home isolation, let him continue the treatment. But you have to quite monitor the blood sugar level. And if you ask me SGLT2 inhibitors, you see the one of the biomarker of the severity is LDH, lactic dehydrogenase. So lactic dehydrogenase means that if the cells are dying, that's why the intracellular enzyme coming out to the plasma, right? But you know, the SGLT inhibitor reduces the LDH. It by the way of its sodium inhibition, it keeps the LDH back to the cell. So in the long run, SGLT inhibitor, if the patient is continuing, I won't stop SGLT inhibitors because of this particular benefit. Let him continue the SGLT2 inhibitors. And ketoacidosis, you know, what is called euglycemic ketoacidosis is no longer a problem. I haven't seen a single case of euglycemic ketoacidosis so far now. And when it combined with gliptin, there's very less chance of this particular complication.
Thank you so much.
Dada kiba kubo?
Yeah.
Ripon sir, good evening.
Good evening, Cock.
Sir, it was
I
really
think all of
fantastic.
you know, sir, Rajesh, just let me, I know, I think Ripon sir, Dilip sir also knows you, Dr. Anupam sir, Anil sir, and Dr. P.K. Sharma sir. Rajesh Dotto is our general head. He is looking after entire East Zone. Okay.
Hi.
Okay.
So, Rajesh, you would like to say anything? Because it's an opportunity for
Right,
you also.
Thank you, boss. Actually, last month I was met Dr. Ripun Pujari, Dr. Sharma. I have met sir along with you, but Dilip sir that time was not there. He was out of station, so we are unable to meet in the last month. Sir, it was really fantastic discussion. In fact, sir, being a salesperson or on the pharma professional, sir, we get training for the product, how to discuss the product with the doctor. But frankly speaking, sir, last almost, sir, 1 month, 2 months, we are doing these views with vildagliptin. And it is my personal opinion, maybe Nazrul boss agree with me, the knowledge we have gathered from this discussion, it is really works. It is really works. Though our knowledge is very, very little, but fir bhi sir, but we really gather very good information. At least we have some talking point right now to discuss the vildagliptin with at least general physician in the country, sir.
Thank you.
So really, thank you very much, sir. Thank you very much.
Thank you.
Sir, one more point, sir. Mr. Sina was discussing after the completion of this session. That is, sir, you all know we have launched Gluvilla 100 milligrams, sir. Sir, actually, sir, we have some information regarding vildagliptin 100 milligram. We have some study, that is bioequivalent study, sir, where we see the 50 milligram BD, that is the innovator brand. 50 milligram BD equivalent, bioequivalent as per with our 100 milligrams are OD. There is no much different. Almost the same bioequivalent almost same.
Rajesh,
Sir,
I want to ask you,
Yes, sir.
if it is a sustained release. Sustained
Yes,
release.
yes, yes,
sustained
yes.
release. Now, will it fulfill the beauty of the vildagliptin that it will reduce fasting blood sugar, it will reduce post-supper blood sugar, it will decrease MACE, it will decrease glycemic variability.
Yes, sir.
Huh?
Yes, yes, yes.
Will it serve by OD doses?
Sir, at this moment, sir, we have two data.
Yes.
Two data. One is, sir, bioequivalence study, which shows, sir, almost 84% bioequivalence is same with OD dose. With BD dose of innovator brand. Difference only 2%. 86% for OD, BD, and 84% with our 100 milligram. Number two is, sir, DTB4 inhibition. 24 hours DT4 inhibition as compared to, sir, this BD dose innovator, it is almost at par. These two information right at the moment, sir, we have for our sir.
Now, I have asked you the question because sitagliptin 100 milligram cannot reduce fasting blood sugar too much level.
No, in fact, the DPP4, the reduction of blood sugar, whatever may be, DPP4 is always a glucose-dependent molecule to reduce the blood glucose.
Yes.
So it cannot have a direct effect on fasting blood sugar, number one. But because of the indirect effect, because of the increase in the GLP-1, that can have a sustained, a better, good effect on the beta cell survivability and beta cell function. And that is why in the long run, it reduces the fasting blood sugar. But basically, if you, it is always a glucose-dependent molecule that can reduce the blood sugar only after taking meal. So it's a prandial glucose that is important for us. And in the long run, because of the very beneficial action on beta cell function, it will reduce later on the fasting blood sugar.
I am asking because I am writing the molecule. Writing the molecule.
That's why I am asking. Here is,
I've seen your prescription, sir.
Highest supporter for us is
that's why I'm asking the questions.
Yes, yes.
All of you are prescribing, but it's good. It is good to put question. That is good.
The thing is that if the fasting goes high and your postprandial within the range, with beta-gliptin, vildagliptin, or any gliptin metformin combination, if you require, you need to give one basal insulin. That's all to have the basal insulin to fulfill the all.
I completely agree with Ripun sir and Dilip sir. The fact is something we called pharmacologically trough level.
Yes.
So when it goes up and then it comes down, the lowest point is the trough level. So where do you want to maintain your trough level? With 50 milligram twice daily, the trough level is higher. You go up, you come down. The moment you come down, you give another 50 milligram.
Another 50.
It doesn't mean how much high you go, but at least you are not below a certain level. The problem that happened with sitagliptin was they started with 100 milligram. It went up very nice, maintained the whole evening. At night, it dipped below the trough level. So in the morning fasting,
I am asking that question only.
Yes, sir. So the morning fasting was high. So is this going to happen same with vildagliptin? Then what will happen practically? The patient will come and say that, doctor, my fasting is high. PP is controlled. Fasting is high, PP is controlled. How to control it?
Then patient will say that previously I am taking twice daily 50 milligram. Now you are giving 100 milligram. My fasting blood sugar rising.
The bioavailability, but the biosimilarity that you calculate is the area under the curve. The area under the curve will be equal, but because though you have made it sustained release, with sustained release the height increases, but the trough level goes down then if you give the BD dose. That is why some medicines are given twice daily, some are given thrice daily, and some we give even at a shorter duration like acyclovir and out. So
you have rightly said, we do to have the full confidence on this particular new preparation, we need to have the lot of bioequivalent studies, studies required. There are few studies are available. You can't
Yes,
just
studies will
really
come
say
up. Studies will come
Yeah.
up. We'll know the molecule better
Yeah,
than now.
definitely.
So thank you so much. Very
Thank you.
nice and very informative discussions is going on.
Yes.
Anyway, Nazrul,
Yes, sir.
please, it is your turn.
Yes, 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 yes. Sir, once again, sir, we take this opportunity to thank Dr. Ripun Bapajari, sir, for moderating the panel discussion. All the panelists for sharing their views on vildagliptin in clinical practice. We would also thank all the doctors who have joined us for panel discussion, and I am sure you will appreciate the views on vildagliptin presented today. We at Alchem Laboratories will continue to serve doctors and patients by making our products available, especially our chronic brands Gluvilda, Gluvilda OD, AM, Jupiros, and Alchem. Thank you. Thank you lots. Thanks a lot, sir.
Sincere thanks to
Thank you very much.
Thank
Sir.
you. Nice
Thank you.
meet.
Thank you, sir. Thank
Nice
you.
discussion.
Thank you,
Thank you so
Professor.
much.
Thank
Thank
you,
you.
Dilip. Thank you.
Sir.
Good night, sir.
Welcome, Dr. Sir.
Thank you, Ripon.
Good
Thank
night,
you,
sir.
sir.
Good night,
Thank
sir.
you,
Good night.
Anupam.
Good night.
Thank you,
Thank you, sir.
Mr.
Good night.
Anil sir,
Thank you, Anil.
after many
Thank you.
days, I'm seeing
Thank you,
you.
sir.
Thank you, sir.
Ripon sir,
Okay.
thank you
you.
very much.
Okay.
Thank you.
Sharma, sir, thank you.
Okay. Okay. Leaving. Thank
Okay,
you.
Okay,
sir.
sir.
Thank you, Dilip sir.
Thank you.
Sir.
Hello?
Because Sharma, sir, আছে আপনি?
ঠিক
হয়,
আছে
হয়, হয়, হয়। Okay, sir. Okay. Thank you, sir. Thank you very much.
ভালে হৈছে বেয়া হোৱা
ভালে
নাই
হৈছে, sir. ভাল হৈছে, sir. খুব ধুনীয়া হৈছে।
মই ইনচেক্ট কৰিলো কেনেকৈ কৰিলো ইনচেক্ট ঠিকে আছিল নে
একদম আপোনাৰ খুব ধুনীয়া আছিলে, ভাল আছিল। বঢ়িয়া, একদম খুব ভাল হৈছে।
ঠিক
Good night, sir.
গুড নাইট